make sure everybody checks that button. So we are recording this, and if you prefer not to have your name or picture displayed, then you can either change your name on your Zoom box and keep your camera off if you do not want your picture recorded. So it's a real pleasure to introduce our moderator for this program, Dr. Elizabeth Wolf Birchfield, Associate Professor of the Medical Oncology at KU Cancer Center and Medical Director of Cancer, Palliative Care, and Geriatric Oncology Services. She's a true friend of the MCA and has a long history of partnering with the community and patient research advocates. So it's always a pleasure when you're here to talk to us, Dr. Wolf Birchfield. So on behalf of the MCA and KU Cancer Center staff, we appreciate you taking time out of the day to be here with us. So let's welcome Dr. Wolf Birchfield. Thank you for moderating this program for us.
Thank you, Hope, and good evening, everybody. As Hope said, I'm Libby Wolf Birchfield, and I'm excited to serve as the moderator for this evening's program. On behalf of the MCA and KU Cancer Center staff, we appreciate you taking time out of your evening to spend with us and amongst all of our population on this meeting. Before we get started, there are a couple of housekeeping items. First, as many of you heard, the Zoom meeting is being recorded. Secondly, if you'd like to ask a question, which we strongly encourage, please ask questions. Please go ahead and type your question into the chat box because we have dedicated time set aside during the program when an MCA staff member can pose your questions to myself and to our presenters. And finally, please be sure that questions and comments don't have any patient information. But I think with all of that said, I think we're ready to get started with our first presenter this evening, someone I'm very proud to call my colleague, Dr. Shen. So Dr. Xinglei Shen is an associate professor of radiation oncology at University of Kansas Medical Center. He graduated with a Bachelor of Science degree in molecular biophysics and biochemistry from Yale University and received his medical degree at the University of Pittsburgh School of Medicine, and then subsequently completed a residency in radiation oncology from Thomas Jefferson University Hospital in Philadelphia. And after completing that in 2012, he joined faculty at the University of Kansas Medical Center. So Dr. Shen, we appreciate you presenting today. Welcome.
Thank you so much, Dr. Wolf Birchfield. It's really an honor and pleasure to be here. So I'm going to share my screen, and if I can figure out how to do that. Give me 1 second. All right. Hopefully y'all see this.
We can see it, Dr. Shen. If you could go up to the display settings up at the top.
Yeah.
And change that so it's in the presenter mode. Right there.
Right there.
Okay, is that good?
Yes, it is. Thank you.
Thank you so much. Well, like I was saying, it's really an honor to be able to present to the MCA and to our patients about some research updates. And my understanding is when Hope kind of talked to me about this was that this was about how giving a progress report or like an update to all of our MCA participants about what you guys did, like how did you change practice? And this is really exciting for me. I'm a prostate cancer radiation oncology specialist, but part of what I do is I'm a clinical trialist, and so the MCA and other sort of these research organizations really so important to me and fundamental to what I think is the how we make improvements, how we get people to live healthier and longer. So what I'm going to talk about today is contribution of MCA participants to prostate cancer research. So I just want to talk very briefly about the clinical trials process. This is something that is not really obvious, it's not something that you kind of know about. So I just want to talk a little bit about the process and really focus most of our time on some of the practice-changing clinical trials that MCA participants helped to bring about, and also end on a little bit about what's going on right now and in the future. So, so I think when we think about like how do we make change, right? We change is a very long process. Somebody gets a good idea, they test it out in a lab, then they test it out in mice, and then we do clinical trials. And after clinical trials, it goes through approval, and then that medication or type of therapy is approved. And this is really important because we don't want to just um, uh, do something that we think is a good idea. We have to prove that it actually works. And where organizations like the MCA, where their crucial role is in this middle portion, this clinical trial portion, where we really, ask people, volunteers, to help the science, to prove that something new is going to be better. So I want to like talk about this role of clinical trials, right? Most new ideas and drugs actually don't work. So a lot as a doctor, a lot of times patients will come to me and say, hey, I read in the New York Times or some newspaper about this new exciting concept. What do you think about it? And a lot of times these are really exciting concepts, and we think, and they're really great ideas, but when you test them, they just don't work in people. People are super complex. If we were mice, nobody would have cancer because we've cured cancer in mice years ago. But what works in mice just doesn't work in people, and so that's why we really have to prove it. And so the way we do that is through clinical trials. And this is testing in people, and there's different phases of clinical trials. Phase 1 is early testing to test safety. And then when we find the drug or treatment is safe, we do a small phase 2 test, maybe 25, 50, 100 people to see if it might work and if it remains safe. And if we get a signal, right, this new treatment, new medication might work, then we apply it to the big test, right, to see, let's compare that versus what we used in the past and really prove that this new treatment works. And this is where the MCA comes in. I think while MCA does have some phase 2 trials in its portfolio, most of the trials that the MCA participates in are going to be these big phase 3 clinical trials that are really designed to prove or disprove a new therapy works or doesn't work. So, I think in that regard, the contribution of the MCA is really, really crucial. It takes many years, as you saw, to complete a study, and we need contributions from everybody to get these studies done, so that we move the science, along faster for people who are diagnosed with cancer. I think if you think about who MCA is, the MCA is this great collaboration of cancer facilities across the region, and what this does is it provides real world settings to clinical trials. And what I mean by that is, some of these early phase 1, phase 2 studies, they might show a signal when you do it in a very, very select group of patients that is, seen at a super specialized cancer center that have super specialized, equipment and whatnot. But then you go to the real world and it doesn't work because, what you have in the real world, the people that you see in the real world are not those ideal, very specialized patients and very specialized treatment facilities. So MCA is, this is the real world, and this is what allows us to say it works in a population and it's generalizable, right? A treatment, not only does it work when we try to apply it across the country. The other thing that's very, very crucial about the MCA is that it does represent a rural population, underrepresented population. This is incredibly important to us and to the country as a whole. We know that rural patients are underrepresented, and one of the contributions of the MCA, even beyond putting patients on these studies is that it provides representation for this underrepresented population. I'm not saying that everybody from CMCA is from a rural setting, but it's overrepresented in the MCA population, and that's really important to have these patients who are underrepresented involved in clinical trials, so that we can say this drug or this treatment is generalizable to the entire country or entire world. Okay, so before I move on, does anybody have any questions or anything about the whole clinical trial process? And feel free to interrupt me if you have any questions. Okay. Well,
They can put them in the chat as
yeah,
well, and we can
cool,
always circle back
perfect.
too.
Yes, thank you. Thank you. That's right. So I want to talk very briefly about the role of radiation in prostate cancer, and how this has changed as a result of the contributions of clinical trial programs like the MCA. So radiation has a role in prostate cancer, either as curative initial treatment or in post-operative treatment. So meaning a patient has surgery, the cancer comes back, we kind of have another shot at curing the cancer by giving them post-operative radiation. And there's also some roles of cancer radiation in patients with incurable cancer. But I want to focus on some of the practice-changing studies that have come about as a result, in part as a result of MCA participation, and how that's changed practice for patients with prostate cancer. So I'm going to give one example of curative treatment, so initial treatment with radiation, and one example in the post-operative setting. So, intermediate risk prostate cancer is, um, um, as many people probably with prostate cancer know, it's a big chunk of patients who are diagnosed with prostate cancer. Maybe a third of people in their time diagnosis will be diagnosed with intermediate risk prostate cancer. These cancers have intermediate cure rates, historically 50 to 60%. It's better now, but historically intermediate cure rates. And some older studies showed that if we add hormone suppression, getting rid of a patient's testosterone for a period of time, that improves the cure rate. But adding hormonal therapy has a lot of side effects. It's increases the risk of heart attacks and strokes. It increases loss of libido, hot flashes, weight gain, lots of hormonal side effects that people don't like. And in modern times, we know that increasing the dose of radiation also improves the cure rate. So the question was that many people had was, well, with modern radiation and higher doses of radiation, do you still need hormonal therapy, or are your cure rates with radiation good enough? Well, so this is a study that the MCA participated in, and was started in so it's RTOG 0815. So it was started in 2008. Prostate cancer trials take a long time to kind of finalize, but this was presented, you'll see this year, 2023. This was actually recently published, I think just a couple months ago, RTOG 0815. And what this study was comparing patients with intermediate risk prostate cancer treated with radiation versus radiation plus short-term hormonal therapy. And this is what they showed. They showed that if you add short-term hormonal therapy, you drop the recurrence rate by half, you reduce the risk of metastasis, and you reduce the risk of death from prostate cancer. What the study did was it confirmed for us that hormonal therapy improves the cure rate, reduce metastasis, and reduce death from prostate cancer. This is despite with modern doses of radiation therapy. So, what this study is, the way this is changing practice is, it's telling us that even though you're using super high doses of radiation now, there's still a role for hormonal therapy. But importantly, what this tells patients is it helps patients have a better input into what they want with their treatment, because not only although we showed that improved cure rates, the differences were relatively minor, right? So what they showed here was that if you didn't do hormonal therapy, yes, the recurrence rate was higher, but at 10 years, it was only about 20%. And yes, there was a higher rate of metastasis, but at 10 years, it was only about 5%. And so what this allows people to do is to make a more informed decision about the kind of the trade-off between side effects of hormonal therapy versus cure rate. And I think this ultimately this helps patients figure out what they want to do given the options that they have. So I do think so. This trial is was just published. MCA was a participant and helped make this trial finish this trial and get this trial done. And I think these results are practice changing in how we talk to patients and give patients the choices between what they want to do for their treatment. The other setting I want to talk about is salvage radiation. And this is basically radiation for treatment of patients who had surgery and their cancers come back. So it's unknown back in the day, right? Like 15 years ago, we would just treat where the prostate used to be, called the prostate bed. But the results of that treatment was that it was successful about half the time. And so we wanted to make that better. And it was unknown is whether in these patients, if we add hormonal therapy, it would help cure rates, and whether if we treated a bigger area, include the lymph nodes in the treatment, whether that would help or not. So in 2005, the RTOG started a trial, 0534, to look at that question, whether if you add hormonal therapy and if you increase the size of the radiation field, whether that would help or not. Again, this is a trial that MCA participated in. And the patients were randomly assigned between just prostate bed radiation, prostate bed plus short-term hormonal therapy, and prostate bed plus short-term hormonal therapy plus pelvic radiation, so treating a bigger area. And this study was published in 2002, so just in the fall of last year. This is just study just came out. And here's what we saw. So these are cure rates basically, and the red line is what we did in the past. The blue line, so about a 10% improvement is if we added hormonal therapy, and you get another several percent improvement if you treated a bigger field by including the pelvic lymph nodes. Not only did it reduce recurrence, it also improved survival, reduced the risk of death from prostate cancer. And ultimately, this changed practice, right? As a result of MCA participants helping finish this trial, we now treat these patients who have recurrence after surgery differently. Whereas before we would treat just the prostate bed, now we treat the prostate bed and the lymph nodes, and we would add hormonal therapy. And what we're doing now is moving patients from this red line to the green line. And that's a big difference in terms of cure rate, and also makes a difference in terms of survival for these patients. I know for sake of time, I'm probably going to just shorten some of the other stuff that I was going to talk about, but there was another trial that the MCA was involved in, looking at shortening the time course of treatment. And this was only presented in abstract form recently. It hasn't not been published yet, but what we saw was that you can safely shorten salvage radiation therapy from 6 to 7 weeks to 5 weeks. And when this gets published, this will also change practice to shorten treatment courses for patients who are getting salvage radiation after surgery. For the sake of time, I probably just kind of run through this real quick, but you'll notice these trials that I'm talking about happened like 15 years ago. And it's because prostate cancer trials just take such a long time to finish and to see the results. But there's a lot of trials that MCA participated in between then and now that the results aren't out yet. And when these results come out, this will also change practice for patients with prostate cancer. And currently we have some ongoing trials that the that are available through the MCA. And again, these are trials. So these trials I just showed are the ones that are completed. We're waiting for results. These are trials that we currently have ongoing right now, and which we think that in another 10 years is going to change how we practice and improve cure rates or reduce side effects for patients with prostate cancer. I want to take one moment to give a shout out to a trial that we have through the MCA that is a investigator initiative trial. This means that we instead of being a cooperative group or a pharmaceutical company, investigators at KU kind of put this together. So this is a trial that actually I'm spearheading with the help of Dr. Worf Birchfield and others at KU. And we're looking at a medication called Relugolix. It is a newer form of hormonal therapy, which seems to have some less side effects, and looking at the optimal duration of this medication when combined with radiation for high-risk prostate cancer. Anyhow, with that, I just want to conclude. We are making progress. I think that's the key point I want to get across. With your support, and your participation on these trials, we are proving like what works and what doesn't work for our cancer patients, and making improving our cure rates and reducing side effects for our patients. And I just think we're just so grateful to all the participants, our study participants, and the people who have contributed to the MCA for being a part of this whole process. Thank you so much.
Thank you so much, Dr. Shen, for such a comprehensive presentation. I really appreciate the way that you've highlighted the meaningful contributions that our colleagues have made and the patients we serve have made to not only their own care, but patients of either today and tomorrow. Tracy, do we have any questions for Dr. Shen?
No, we have no questions at this time.
Well, I'd actually love to, and please feel free. I'd be very comfortable for anyone to unmute themselves and speak up to ask a question or put something in the chat now as well. But I'll lead off, and I would just ask, Dr. Shen, I know you kind of sped through this part of your talk, but I'd be really interested, in addition to highlighting the trial that you're spearheading that's so important in looking at treatment duration, I would also highlight that one of the reasons that's so important is because there was also some data presented at the 2023 GU ASCO symposium that shows that the duration of that for which patients receive androgen deprivation therapy is associated with kind of an inverse or a lower likelihood that we'll see testosterone recovery, and that there are a couple of reasons why the trial that we already highlighted is so important, because number one, it uses an agent that works in a different way, and for which we have some data from the HERO trial that testosterone recovery looks superior to some of the older agents. And also, I think the question of duration, what duration do we have to have? I think because when I talk to patients in clinic about duration, a lot of times they say, well, what's the minimum I can get away with? If I need 18 months, could I make it 15? And a lot of times what I'm forced to just say is reality, which is we haven't tested that duration. So I think more data in that way is so important. In addition to that trial, are there any other trials that we have open through the MCA that are posing some really important clinical questions that you think we should all be aware of and consider either opening or participating in or offering to folks?
Yeah, absolutely. I think I think where we're moving towards in patients with intact prostate cancer is personalizing medicine a little bit more.
Mm.
And so, for people with prostate cancer, you're very well aware of like this Gleason score, right? Everybody knows what their Gleason score is. And what that is a pathologist looks under the microscope and says, okay, your cancer is, a little bit funny or really funny looking, and assigns a score. And the more abnormal the cancer cells look, the worse the score. And that's for the last 50 years, maybe 40 years. That's how we've decided how aggressive a cancer is. but now we have so many more tools to say not only how it looks, but and remember, there's a lot of variability between one pathologist and another pathologist. Not only how it looks under the microscope, but also the genetic factors, the genomic features of these cancers, what proteins they're making, and what pathways are active to that are driving the cancer. So, in that vein, there's the product called Decipher. It's a test that looks at all the proteins your cancer is making, and gives you a score of how bad it is. Basically, it's independent of the Gleason score, the pathology report. And so we have two companion studies in intermediate risk patients and in high risk patients using the Decipher score to customize or to personalize treatment a little bit. So if the Decipher score is low, we are either decreasing or getting rid of hormonal therapy altogether because we know those patients are going to do well. If the Decipher score is high, we know those patients are going to do worse or poorly, and we're looking at escalating treatments for those patients. So it's a very simple study, and I think no matter what, patients either get standard of care, what we normally do anyway, or something which I think rationally is a more customized and personalized treatment that is better.
It's such a privilege to be able to practice in a time when in one disease and essentially sort of one disease state overall, we're investigating both de-intensification and intensification. I think, for so many conditions now, the field is really going one way or the other, but I think it seems, in some ways might be on the surface paradoxical, but I agree, it really highlights just the ways that we are striving to personalize care for people affected by this disease. Those are really great trials. And would you remind us which trials are these?
Sure. So their names are NRG, which it's a cooperative group, NRG, GU, that's genital urinary cancer, GU 009, which is the high risk trial, and 010, which is the intermediate risk trial.
Wonderful. Those sound like great opportunities. Well, I see a hand up.
Yes, I have a question for Dr. Shen or anybody else that participates in clinical trials. This last week, the Wall Street Journal had an interesting article that headline was something like, "Do I really have cancer?" And it went through the diagnosis of a lot of different patients, different types of cancer. And then it talked about getting a second opinion. And a second opinion sometimes confirmed that the person had cancer or didn't have cancer, and how important it was to get the second opinion. Mm-hmm. That was all fine, but the part that kind of got to me was the lack of a second opinion might be distorting clinical trials if you have those initial populations where you don't have the second opinion, you're going to get a distortion. And it kind of concluded that a lot of times the clinical trials, the results of that are not quite borne out in the general population.
Yeah.
Can you speak to your clinical trials and the second opinion factor?
So great. That's a great topic. So we do know that diagnostic accuracy is not equivalent, right, across the country. And so some trials require central pathology review, meaning, you make a diagnosis based on a biopsy. You have to prove that biopsy is correct by sending the tissues in to the clinical trial office, and they'll overread it, and then it kind of provides a uniform, level of diagnosis for everybody in the trial. The problem with doing something like that is it delays things.
Yeah, of course.
Right. So you have to get the materials, and if for a center like ours, for instance, right, I will often see patients who are diagnosed at a another plate, another facility, right? And so I have to get the slides from that facility, and then once I get them, send them off to the third facility to like get it read. And so for pragmatic purposes, so when the pathology is super important, sometimes we go through that effort, because if his pathology is crucial. For instance, a lot of brain cancer trials require, because those are hard, require these centralized review. For prostate cancer, there's these studies that we're doing are asking thousands of patients to do this. So it's kind of it's a even though there might be some individual discrepancies between pathology from different groups, what that gives us is kind of what they call it pragmatic design or pragmatic results, meaning even though there might be some discrepancies between different groups, this is representative of the overall population. And I think this is part of the reason why, like, a group like the NRG or the RTG, like, why these groups exist, because most of the members of these groups actually not the big academic facilities. It's people like the MCA and other kind of NCORE, different groups, which is a representative of a general cancer, cancer hospital across the country. But I do have to say, this, for an individual person, right, this quality of the diagnosis is very important. And in a personal practice, many times I'll get like our pathologist to look at the outside diagnosis to confirm the diagnosis. But where we're moving towards as a field and as a as in cancer, is to offer treatments, things which are basically second opinion. So for instance, this is Decipher test, right? It is independent of the diagnosis. And so anybody, no matter where you get your biopsy from, you can get a Decipher test. And that kind of levels a playing field for everybody. There's also another product out there, which is going to be in the next generation of these testing, called Artera. And what that is you send a digitized picture, I guess, of the biopsy. So you don't need the actual slide. You send a digitized picture, high resolution picture of it, to a company, and they look at the features, and it gives you a result based on what it looks like for the digitized slide. And what that does essentially is levels the playing field for everybody, because if you do go to a central repository for diagnosis, or central, commercial product that is a centralized form of diagnosis, then everybody gets the same, quality of diagnosis.
Thank you.
That's a great point, in the idea that there is kind of this unofficial second opinion built into the trials. I've actually never really thought about it that way. That's so true. I do see one question in the chat, and we can, I think, address that and then go on to our second presenter. But it asks, what is the threshold to get into a clinical trial? And I may need clarification. So if I don't answer the question, then please do add another question in the chat that we can use to follow that up after our next presentation. So I don't know if that's talking about how healthy someone needs to be, or what specific qualifications might be necessary. So each trial looks a little bit different in terms of how someone's their cancer state and stage, prior treatments or lack thereof. And so that's individualized for any given clinical trial. I would say that if we're talking about how healthy someone might need to be, for example, to participate in a trial, generally speaking, folks who are kind of living in a community setting and taking care of their own daily needs and their own self-care are usually healthy enough to participate in a trial. Sometimes there are, depending on if it's a clinical trial that uses medications, then sometimes there are specific requirements related to the mechanism of that medicine or interactions that medication might have. So sometimes clinical trials might say, if someone's going to participate in this trial, they can't be taking amiodarone for their heart because there's a significant interaction. So sometimes there are sort of nitpicky details like that, but I realize that's a very general answer. So please ask follow-up questions in the chat. But I think that since we've answered some questions, I'd love to go ahead and move on to our next presenter, another wonderful colleague of mine, Dr. Eugene Lee. So Dr. Lee is an associate professor of urology at the University of Kansas Medical Center. He is the director of urologic oncology and the program director for the Urologic Oncology Fellowship at KU. Additionally, he leads the clinical research program for the Department of Urology. And after finishing his residency at the University of Kansas Medical Center, he completed a urologic oncology fellowship at the University of Texas MD Anderson Cancer Center. So he is a surgeon scientist who focuses on urologic cancers and strives to create a personal bond with each and every one of his patients. And boy, does that come through. And because we share a number of patients, I hear that all the time, that it's quite apparent that in his effort is fruitful. He performs both open and minimally invasive surgery, including robotic surgery. And while surgery may be required, he always discusses a comprehensive plan of nutrition and mental health with every patient, consulting with him. It's also important to doctor that he can coordinate a comprehensive treatment plan involving often medical oncology, radiation oncology, as well as pathology and other surgical services. So Dr. Lee, thank you so much for joining us this evening. Welcome.
Thank you so much for this opportunity to present today. Thank you for that introduction. I'm really going to focus on a couple of studies that we've run through the department, mainly focusing on bladder cancer and radical cystectomy, which is the surgery to remove the bladder, typically done for cancer. And so I'm just going to go ahead and jump right in. Radical cystectomy is a very technical operation with a fairly high complication rate. So 64% of patients will have a complication within 90 days, and about a quarter of patients will get readmitted into the hospital within 90 days as well too. And about a quarter of patients will have a major complication. One of the factors that we've known about is malnutrition, which really predicts and correlates with poorer outcomes, as evidenced by this very nice study that was done. Those patients with nutritional depletion had a 3 times higher 90-day mortality and about 22% lower 3-year survival if they were deemed to have malnutrition. So clearly, this is an area of need that we need to work on in improvements for these patients. A couple of reasons for malnutrition in this particular patient population is that many of them have undergone chemotherapy prior to the radical cystectomy. And we know that up to 73% of patients who undergo cisplatin chemotherapy, which is one of the most common regimen for bladder cancer, have dysgeusia, or smell and taste changes, which affect the way people eat. Additionally, patients will have diarrhea, constipation, which lead to poor oral intake of food and fluids, and then also malabsorption of nutrients as well too. And so if you look at the guidelines for treatment of muscle-invasive bladder cancer, it's clearly stated that clinicians should optimize patient performance in the perioperative setting. And this is really, a lot of it is focused around nutrition improvement. So our goal was to collaborate with not only medical oncology, but also with nutrition and dietetics, and with the School of Communication to create educational video series, really outlining some key goals and objectives when it comes to nutrition education. We wanted to do this in a practical way so that patients and caregivers can watch these videos and really use the education that they're learning in their everyday lives. And so we wanted to record about 4 to 7 episodes per topic, each about 3 to 5 minutes, so that it's really digestible in small snippets, and people can take that with them and actually modify what they're doing in their own home. We used emotion elicitation audio and filming, which basically means that it was movie-like filming. And again, we had help with our collaborator from the School of communication.
Looks like we're having technical difficulties, so we're trying to get that worked out. Apologize for the delay.
Center where the all of the recordings were done at the University of Kansas Clinical Research Center, where we had a teaching kitchen, which was amazing to be able to use that. Our actors in these videos were physicians, including Dr. Wolf Birchfield. We had nutritionists and dietitians and members of the research team also involved in video recording. Once we recorded the video, we did video analysis. This was a software program where we could look at the actors and evaluate based on their facial expression, their body language, that we were portraying the message that we really wanted to get across to the future patients that would come across these pages and web pages and videos. With the video assessment, we also wanted to hand it back to the folks that we really wanted to target for this, and which is obviously the patients and the patient advocates. So we, again, recruited additional patients, 12 that were undergoing radical cystectomy at the time, and 4 caregivers as well, too. And we showed the videos to them, and we surveyed them with focus groups, making sure that we were, again, conveying the message that we wanted to convey, and that they understood all of the things that we were trying to teach throughout the videos. And then also asking, do you think that this would change your behavior? Do you think that these recipes are things that you could do at home? And then in terms of the videos, the last assessment prior to modifications were eye tracking. So this is a very nice technology where we could actually show the videos to participants and see where their eyes are going and for how long their eyes are going to certain areas in the video, making sure that the eyes are getting drawn to the information that we're wanting to get across. And then lastly, we created a feedback instrument. We wanted to have questions at the end of each of the video series just to make sure that it was understandable, that the information was being conveyed. And so again, we used an advisory board where we developed the items, we had expert content review, and then again, we had interviews with the target audience, which is obviously the patients, and wanted to know from the patients, are the questions asking what we think that they're asking? Is it really testing your knowledge? And so we had the patients involved in that portion of the study as well. And then at the end, we were able to create these knowledge questions that we will be adding to the end of the videos to make sure that, again, patients are understanding what we're conveying. And the final product, if you look at the Bladder Cancer Advocacy Network webpage and you go to nutrition for bladder cancer, you'll find several of our videos and embedded within the website. You'll see a lot of the work that we've done. We always appreciate the opportunity to be involved in a project like this through the funding that we received from Beacon. Changing gears a little bit, this was another project that we were involved with that I led through grant funding through the University of Kansas Cancer Center through some pilot funding. And again, bladder cancer patients undergoing radical cystectomy, just by clinical care of patients, we really have grown to know some of the areas of critical need, including, again, malnutrition, which I won't hammer home any further, but frailty and physical deconditioning is one of the problems that lead to poor outcomes in patients undergoing radical cystectomy. In addition, patient education of expectations and outcomes. Some patients were concerned with poor communication with the care team, mainly they didn't know who to contact, and then also patient compliance with treatment. So skipping over malnutrition and going to physical inactivity, obviously patients who have physical inactivity have decreased muscle strength, decreased bone density, decreased lung function and capacity, and then increased risk of heart disease. And so that's obviously the second thing beyond malnutrition that we need to address, which we wanted to address in this second part of our study. Number 3 is patient education. So, patients undergoing gynecologic surgery, up to 30% to 33% of these patients actually didn't know any of the complications or risks of some of these surgeries. So obviously that's a problem in this particular patient population. And then communication barriers. So staff to care team delays when you're trying to communicate just by telephone, inconsistent points of contact, and then poor education prior to discharge. And so that was one aspect of care that we wanted to affect. And then medication compliance. So, in this study of breast cancer survivors, they showed that depending on the type of medications, many of these patients were non-compliant with their home medications and some of the medications that they needed to take because of their breast cancer treatment. And so the way we wanted to address this was actually to develop an app that was smartphone. We used an iPad so that we had control of how that information was getting to the patient, just in case also that they didn't have a smartphone at home. So we collaborated with a company called Life Science Technologies, excuse me, to create an application for patients to use around the time of radical cystectomy. So the LST app is bidirectional, meaning that the communication happens both ways. It is HIPAA compliant and has little applets or little programs within the big app that we could utilize for certain aspects of what we wanted to manage in this patient population. So from a malnutrition standpoint, we had patient-centered malnutrition screening. We had trained nutritionists giving dietary recommendations, working with them on taste alterations and high-impact foods, and some of those videos as well. In terms of physical deconditioning, what we incorporated was an accelerometer or a watch. So it was a Garmin Vivo Fit that we used, and we developed patient-based, goal-directed steps for each patient. So we gave target steps for each of the participants. The Garmin Vivo Fit would sync directly with the app so that we would be able to track the number of steps that they were taking each day. So from the provider level, we were able to see on a daily basis how many steps they were taking, as you can see by the rectangle in this slide. In terms of patient education, we created a video series of educational videos on bladder cancer basics, radical cystectomy, risks of radical cystectomy, managing diversions, etc. And these videos were pushed out through the app at certain time points as not to overwhelm participants right off the bat. So, 2 weeks prior, they would get 1 or 2 videos. 3 weeks prior, they would get 1 or 2 videos so that it was manageable. And then in terms of communication, part of the issue is not only the person to communicate, so they all had a point person, which was our wonderful nurse practitioner on the floor, and then each of the participants after surgery took home a discharge box that had a thermometer, pulse oximeter, blood pressure cuff, and a scale, so that they were able to take their vitals on a daily basis, and this would automatically sync with our app. So again, from a caregiver point of view, we were able to monitor vitals with the hopes that we would be able to intervene prior to major issues that we would notice some abnormalities in the vitals. And then lastly, treatment compliance, especially with medications, making sure that they're taking their antibiotics, blood thinners, stool softeners, and pain medications. And again, we were able to monitor this by sending reminders, and it would the participants would have to hit a button to show that they took certain medications. So if you look at our results, we started with 25 participants that we offered the study to. Unfortunately, 5 either declined or didn't have Wi-Fi in order to participate in the trial. So we had 20 total that initiated the trial. Some patients had disease progression or withdrew consent, with a total of 15 patients, which is not bad for a pilot trial like this to show proof of principle. When you look at the ambulation and accelerometer data, we found, as expected, that more than half of these patients would actually sync their accelerometers to the app on a daily basis. And by their actual steps, we saw that pre-surgery, they had a higher number of steps than inpatient right after surgery, but then post-operatively, a great number of these patients improved their walking. And I think that when we talked to them afterwards, they really all showed kind of a motivation, even just by being a part of the study and having the watch to really count their steps. And so I was very happy to hear that. And then maybe the most important portion of the study was the vital signs and the triggers. And so when we would see elevations in their temperature, we would contact them and check on them. Sometimes we were able to intervene with outpatient antibiotics. Again, if we saw any changes in their pulse, we were able to call them. If they had signs of dehydration, we would set them up for IV fluids, and hopefully with the goal of preventing readmissions. And so really with this work and with the participation of these patients, we were able to get a lot of great data in terms of how feasible this is and what are the next steps in terms of how we can use these types of technologies in the future. None of this work could be done without a huge list of collaborators and researchers, participants, but especially our KU patient volunteers and advocates, and then the Bladder Cancer Advocacy Network. Without them, obviously none of this work would be possible, and we obviously do it to improve the care of patients with bladder cancer. So with that, I will finish. And I think there will be a time for questions, and thank you again for letting me present today.
Thank you so much, Dr. Lee. We're really grateful for your presentation. Tracy, do we have any questions for Dr. Lee?
Doesn't look like we have any questions at this time.
Both of you have been so thorough. One question did occur to me that's perhaps pretty relevant to some of folks in the Masonic Cancer Alliance. So Dr. Lee, certainly this outlines a really incredible track record of patient-centered research, looking at kind of quality of care, and as well as, trying to reduce complications for bladder cancer therapies. One other trial that it seems like it's in line with this is the one spearheaded by Dr. Hamilton Reeves, the S1600 trial. Is that a trial that still is enrolling right now? And I think that it is, and it is a cooperative group trial. It also has patient-centered outcomes. So I wasn't sure if you had any particular, if there were any anecdotes about any patients that you've had who participated in that, or if you'd be comfortable providing a very brief summary. I know we only have a couple of minutes, but if not, then I might be able to orient everybody to it.
Yeah, so first of all, sorry about the technical difficulties. I recorded that so that we wouldn't have technical difficulties. I didn't know in the setting I'd be in what my Wi-Fi capacity would be. So I apologize for that. And thank you so much for the opportunity to present. So yes, one of our wonderful collaborators, Dr. Jill Hamilton Reeves, she's a PhD in dietetics and nutrition. And it's really not common to have principal investigators on these multi-institutional SWOG type trials. And to have somebody like that within our own department is just amazing. So just a little bit of background, it's basically an immunonutrition drink. So it's not just a standard like nutrition protein shake, but it actually has immune modulators in the drink. And so patients are asked to drink 5 days before and then 5 days after surgery. And we've really shown in our preliminary data to demonstrate that patients are having a less incidence of perioperative infections. And then anecdotally, looking to see that they're recovering quicker, et cetera. And so, as we've discussed with these types of trials, it's so critical, just given the extreme nature of their recovery process. So not only is bladder cancer, unfortunately, a devastating cancer to treat from a cancer standpoint, but unfortunately, the recovery from a lot of the treatments that we have are extremely difficult to manage as well, too. And so, we're really lucky. It is still open. We're continuously looking for patients to enroll in this clinical trial, and so far, I think that we are doing a pretty good job. So thank you for letting me highlight that.
Oh, wonderful. Yeah, I think it's another great way, just as Dr. Shen highlighted earlier, that the MCA has contributed, is contributing, and will continue to contribute to advancing the greater knowledge for genitourinary cancers. So, and let me see, I was just going to take a look in the chat to see if there's anything directed at me. But given that we have only a couple of minutes left, certainly if anyone wants to unmute and ask questions, you're very welcome, or put anything in the chat. But as we're giving a little time and space for that, I just absolutely want to thank our presenters for sharing their time and their expertise with us today. And it looks like, let's see.
We do actually have one question that came in.
Great.
And I will read this. It says, "My apologies if Dr. Lee shared and I missed it, but what are the next steps for the studies you presented on? I'm guessing you're applying for a next round of funding?"
Yeah, so ever since we, I'll speak more to the app. Ever since we published that, and we were lucky enough to publish it kind of on the early end of the cycle in a way. There's been several other publications in that same population, but yes, we are looking to apply for NIH funding. And it's a little bit of a tricky process because of the app company itself. I haven't been able to work with them for various reasons, but we're always looking for partners, and that's kind of the holdup at this point in time.
All right. What an academic story. Well, as all of you, I hope you see in the chat that we have our CE code, which is 72GEUM, with no space between letters and numbers. And it looks like we have one more question that I might be able to address, which is circling back to questions about sort of participation in clinical trials, and specifically about how complicated cancer must be for someone to participate in a clinical trial. I would just say that so we have clinical trials investigating new ways of treating, either de-intensification, intensification, helping quality of life, quality of care, all sorts of aspects of treating cancer across the entire spectrum. So clinical trials are not only for advanced cancer. We also have clinical trials that are the first treatment someone might ever get, for first and only treatment they may ever get for their cancer. So it could be early stage curative intent cancer. It could be low volume cancers. I would say that while there are a number of clinical trials focused on treating cancers that are advanced, including those that may have had prior treatments, their clinical trials are not limited to that, and we have an entire spectrum of opportunities there. So I don't think we can find something for everybody, I would say. But What a wonderful question to close the session. I greatly appreciate all of you who have participated this evening, and I'm honored by you spending part of your evening with us. We appreciate you having been here, and please, all of you, stay safe and healthy and have a great evening. Thank you again.